on COVID-19 series. I'm Hala Ali, the coordinator of Eastern Alliance for Global Health Partnerships. These webinars take place on Fridays at 12 p.m. GMT. And every week we host experts from the healthcare and global health fields to discuss with us various aspects of the COVID-19 pandemic. This webinar is the 12th in the series, and today's topic is the positive power of communities in the response to COVID-19. A recording of this webinar will be available later on our website and YouTube channels shown on the screen, Irish Global Health Network and Eastern Alliance for Global Health Partnerships. Live streaming is also available right now on our YouTube channel, Irish Global Health Network. If you have any questions during the webinar, please use the question and answer feature in the bottom of the screen. For now, I will leave you with my co-host, Nadine Fers-France, the Executive Director of Irish Global Health Network. Nadine?
Thanks, Hala, and welcome everybody. Really excited for today's webinar, as it's a webinar, a subject very close to my own heart, focusing on communities. Also really delighted to welcome some very good friends of mine and people who are very well known to communities around the world. Starting with Nicola Willis. Nicola is the founder and the executive director of Africaid's Jandiri program in Zimbabwe. She's trained as a pediatric and adolescent HIV nurse, first in the UK, before she worked in Ghana, South Africa, Kenya, and then has lived and worked in Zimbabwe since 2004. With Jandiri, she has been with her team assisting government and health facilities and communities to establish pediatric and adolescent HIV treatment, care and support services, which are really phenomenal. And I'm really excited that we get a chance for everybody to learn more about them. So welcome, Nicola. Also delighted to have Florence Martin-Boer with us. She's from Kenya. She's in Kenya today. She's the coordinator of the Brighter Communities Worldwide in Kenya. She's a member also of the West of Ireland Kenyan Steering Group Committee. So this coordinates, and we're very familiar with this incredible partnership between Londiani Sub-District Hospital, the Department of Health in Karachi County in Kenya, Mayo University Hospital in Castlebar in Ireland, Kenyatta University, and also NUIG in Galway in Ireland. So very welcome, Florence. And we
Thank
will
you.
Welcome. We are also delighted to introduce, she'll be joining us hopefully very soon, Wine Kwat. She is a medical doctor and founder and executive director of the Centre for Supporting Community Development Initiatives, SCDI. No stranger to Ireland, Wine was here as a keynote speaker for the Father Michael Kelly lecture on HIV AIDS in 2018. SCDI, as many people will know, it's a Vietnamese organization, an NGO, and they focus on improving the lives of marginalized populations through community empowerment. And they particularly serve marginalized groups, sex workers, drug users, people living with HIV, transgender people, and many others. Wine has also got vast experience. She's the chair of APCASO, the Asia Pacific Coalition of AIDS service organizations, and she's the civil society representative on the UHC 2030 Steering Committee, Universal Health Coverage Steering Committee. Last but not least, delighted to welcome Blessina Kumar from India to Ireland also today. She is the CEO of the Global Coalition of TB Activists, the first and the only global network of people affected by TB. And many people will know GCTA is at the forefront of advocacy and capacity building for advocates and activists around the world. And their mission is to change the status quo for TB. She's also co-founder of Touched by TB, which is the national coalition in India of people affected by TB. So an amazing lineup of speakers and experiences to share today. First, and I want to go over to Rory Brewer, Professor Rory Brewer, our webinar anchor, who is former head of the Department of Epidemiology and Public Health in the Royal College of Surgeons. So thanks for kicking us off, Rory.
Great. So I don't know if you can let me know, can you see my screen?
Not yet.
Ellen, is the screen, do I need to share again?
I think you'll need to share there again, yeah.
Sorry, where are we? This always happens, and then we give up and go back to Ellen, who's probably a lot more reliable at these things.
It could be, Rory, could be.
Okay, I'm just sharing screen again. Okay, is it coming in this time?
Yep, we're looking at, yep. Perfect.
Okay, and okay, can you see this first slide there?
Yes.
So those of you who have been listening in these webinars over the several weeks now, we just start off with a global overview. And what I put there on the front page at the bottom was just a number of cases, cumulative cases, deaths, but also those recovered. And I think it's important to realize while many people are ill, at least half of the cases have actually recovered now. But when I put those, I put figures up this morning, and I just corrected them now. So since this morning, there were 34,000 new cases and 362 deaths. So it's a very much alive pandemic. And last week, you'll recall, I showed a slide like this with a number of the countries, and we were looking at low and middle income countries and the impact of COVID-19 on the health systems. And Brazil is a high middle income, India, low middle income country. So what we've shown here is actually just the trajectory over the last week. And we've included just a shorter selection of countries, including those represented on the panel today. And what we can see is just the scale of the pandemic in Brazil. We've seen 177,000 cases over the last week. That's new cases. That's a 40% increase, and 7,275 deaths. The scale of the pandemic in India is similar, just a 36% rise in cases, almost 60,000 new cases in the last week. And South Africa, while we're looking at lower numbers of cases reported, there's 49% increase in cases. So it tells us something about the stage of the pandemic in these countries, where they're really, it's at its worst, and it may not even have reached its peak yet in Brazil, which is the appalling tragedy of appalling leadership and what the result of that is. When we look at the other countries there, we see probably an earlier stage of the pandemic in Kenya and Zimbabwe. Vietnam, now that's really notable. I'm going to say a little bit about that in a couple of minutes. One case since last week, no deaths at any stage. And then at the bottom, we have Ireland, where there's been a 1% increase over the last week. So I was trying to think, because people on the panel here are the experts in this area, but I decided just to go back into my own history to look at what are some of the seminal events. And I started working in Africa 5 years after the Alma-Ata Declaration. And I think what you can see a definition there of the principles of Alma-Ata, what it was trying to achieve. But what was notable, I remember reading many years ago, was that it was really the work of NGOs and faith-based organizations and the initiatives that they had been running for several years. That is what was brought together at Alma-Ata. And while it was representatives of governments from 60 countries, the NGOs, the FBOs, the different community initiatives were all represented there, meeting on the periphery. And when I went to Ghana in '83, it was very much implementing and trying out these primary healthcare approaches. Second initiative I put up there, because I came across it in the '80s, and I think this was developed particularly in Kenya, which is adapting Paulo Freire's pedagogy of the oppressed principles for working with communities. And what I thought was interesting there, those are the chapter titles, and they would be so relevant today, not only to COVID-19, but to what we're seeing happening in the US at the moment. Environment, gender and development, racism, culture, and transforming governance. The next event I've picked on is HIV and AIDS, because I don't think we could have got anywhere towards the successes we achieved in Africa if communities hadn't banged on the door. And I was there in Geneva at some of these meetings, and they had to shout very loud The treatment action campaign is one we would look at, but there were many other initiatives, and I came across some initiatives in Zambia where women down at the community level were told, you're going to get funding from the World Bank. They started income generating activities for the care of orphans and vulnerable children. The money never came, but the initiatives they started were still working 5 years later. So I think we're really looking forward to hearing today now from the panel of speakers about some of the community initiatives which could transform the response to COVID-19. In Ireland, we many of us know the GAA are very much at the centre of every community, and they have their initiative, and there's some notable initiatives like this community assessment hub. But I thought I would just mention Vietnam because I have one point I want to make today, and it's a bit of a challenge to us, because if you look at, this is the success story which nobody has been talking about. A country of 97 million people, no deaths. These are some of the things they did. They acted very early, closed the ports, the airports, quarantine, travel restrictions, lockdown, very good communication strategy, rigorous contact tracing. But what I put in bold there is that they made tracking and quarantining of cases mandatory. And I think that is a challenge to us, that this was done much more easily in Southeast Asia than I think we would find here. And I think there is a challenge. South Africa I put up because it's been lauded for its response, its early lockdown, but we talked about this last week and in previous webinars. What are the impacts on the urban poor, on food insecurity, on inequities, people not able to go out and just earn, get the food they need for that day. And I think there are some very good community initiatives out there. I just put one link in. So finally, what are the conclusions from this? I think we would say the voluntary approaches are preferable to coercive approaches. You can read what I have there in the slide, and thanks to Foreign Affairs and IDS for putting together some information and some links there. Maybe the key thing there is about trust, and that some of these lockdowns have undermined trust because they've shown no respect for people. And yet in Southeast Asia, trust in the state and allowing the state to be putting draconian measures in place, that is something that actually the people have bought into. And I put an end at the end there, this uneasy marriage of trust and coercion, because the measures that worked in Southeast Asia, they're not working to the same extent elsewhere. And I think we have some very difficult balancing to be done. So I hope I didn't go on too long, and I'm really looking forward to the panel of speakers. Thank you, Nadine.
Thank you, Rory. Thank you for kicking us off and with thinking about trust as well. I think that's an interesting one that's coming up across the webinars. So I would love to go straight, if we can, to Nicola and to the situation in Zimbabwe, because we have heard over previous weeks, just the situation with lockdown and what's been happening there. So Nicola, I wonder if you could just describe to us what has been happening, what's the situation like at the moment, particularly for communities affected by HIV, and particularly for those young people that you're working with every day affected and living with HIV. You're muted, Nicola, just unmute. Yeah.
Thank you. I'll eventually get this mute, unmute thing by the end of COVID. Right. So thank you so much for the opportunity to be part of this really exciting webinar. As we've just been hearing, in Zimbabwe, there are currently 237 confirmed cases, 4 deaths. So while this is encouraging, there has been a spike in the last few days, and testing is being rolled out. So we'll see what happens. But as far as we know so far, there have been of those cases, just a very few have been in children and young people. And what we're seeing among young people living with HIV that we're working with is, fortunately, we're not yet seeing cases, but we are working with the Ministry of Health as they're rolling out testing to make sure that testing is reaching those young people. We are, however, of course, seeing the tremendous impact of COVID on young people. definitely around the impact on their mental health, arising from social isolation, from fears around their health. Will they be able to access the ARVs? Difficult decisions, you know, they know they need to go to clinic for ARVs, but they fear of getting COVID when they're moving around. They also fear having to explain why they're moving around, and do not want to understandably disclose that it's because I'm HIV positive and I need to get my treatment. So that's been a real barrier to them accessing clinics. They're hungry because caregivers don't have the usual household income or access to food. Yeah, and they're experiencing increased levels of household stress, increased levels of GBV. So yes, definitely having an impact. But I think, you know, we may well be early days in COVID in Zimbabwe.
Yeah, thank you, Nicola. And, you know, just in terms of Jandiri, how did you respond? I mean, it's still early days, and I know the response is no doubt changing as you go along, but how has Jandiri responded to make sure that the young people and the communities that they're living in are supported? What did your community response look like? And knowing very well that builds on a very strong community response that's already there.
Sure, thanks. Definitely, as you've implied, I think it's probably the same for all of us. We're thinking on our feet, it's changing daily, we're learning, we're getting some things right, some things wrong. But for those of you that just a bit of a background, we work with a cadre of young people living with HIV. They're 18 to 24 years old. And they work in the communities, but also in the clinics to support their peers living with HIV. And they provide information, counselling, support. They support them to adhere to the medication, but also looking at other issues of mental health, sexual reproductive health, etc. So they do home visits, they see them in the clinics, they engage through support groups. And of course, all of these platforms have been very difficult or impossible and had to be put on hold because of COVID. So what did we do? We adapted most of this to a virtual approach of service delivery. So CATS have been just phenomenal in their commitment and their ability to ensuring that they continue to support their peers. So using WhatsApp or SMS or phone calls, they're doing virtual case management. So they continue to track their caseloads, calling them, providing online consultations, counselling support, identifying those that are unwell or those that need access to ARVs who are running out of treatment. They screen for common mental disorders and refer those that are at risk. And they're looking out for those with any other issues that need additional support.
And Nicola, can you just tell everybody what are CATS? Sorry,
I meant to say that. Thank you. CATS are they're not animals. They are young people, fabulous young people who are peer supporters. They are trained and mentored as peer counsellors. Yeah, community adolescent treatment supporters. Thanks, Nadine. So the support groups have also gone virtual. We've been talking about this for so long, you know, trying to do more virtual groups so we could reach more young people. And I'm sure, like many of us, COVID has catapulted us forward with many of these things we've and ahed about for a while. But the e-support groups are incredibly popular among young people, and they're dialing in on through WhatsApp. We've also piloted these for caregivers, and it's wonderful to see grandmothers joining WhatsApp support groups. We didn't actually think that would work, but they're really, really engaged, and it's such an important part of supporting young people, of course, by remaining engaged with their caregivers. Not everybody has, of course, access to phones, so we have a wonderful team of professional social workers, counsellors, nurses who are mentors in the communities, and they move around to follow up on young people who need to be seen at home. So yeah, really it's sort of a switch to a virtual approach, but then enhanced community outreach for those that really need to be seen and are at risk.
Yeah, and thank you, Nicola. And for sure, if Zimbabwe can do it with the situation, not just with data, but also with electricity shortages, then any of us can do it. So I know that there is such creativity among the cats, among the young people in Gendiri, and I know that because it was my last trip before COVID and before lockdown was actually with all of you working on stigma there. And I just wonder, what creative solutions have you guys, what would you say is something that's really creative that they came up with, the young people came up with themselves?
Yeah. Well, I think you've just said, I mean, it's the young people that they're the creativity in everything we do, and just just to highlight their commitment to finding ways to continue to engage and support young people, not just for HIV and ARVs, but for their mental health. When young people themselves, they're facing just the same issues that we're all facing, and so they have this added work on top. I think I would highlight the information and communication work that young people have been involved with. So we saw very early on, as we all saw, there was such a barrage of information, and we were trying to sift through what do you read, what do you not take notice of, or and young people were terrified, of course, and very confused. And so I think we put a lot of work and time into working with the young people on what information did they need, did they want to get, and making sure that we worked with young people to develop information that was developmentally appropriate, that was evidence-based. Normally when we do these sort of videos or animations or materials, we'd get together in a room and work together on content. We'd go off to a recording studio, and of course none of that was possible. But it's incredible what can be done on a phone. And from young people, they'd wait till late in the evening to record their narratives and their transcripts, so that it was ever so quiet and they could get the right quality recordings, etc. So yeah, we've developed a series of films around COVID, HIV and treatment, and there's more to come. They're available on our website. I think there was a suggestion we may be able to play one of them or part of one of them, but please do get in touch if you need those, and they've been translated as well.
Yeah, Nicola, thank you so much, and we would love to just show just a short clip of one of those amazing videos.
Hi, it's Fatima. I'm living with HIV and I've been taking ARVs for 5 years now. I know I must take my ARVs every day if I am to stay healthy and strong. So when I started hearing about the new coronavirus or COVID-19, I started to get really worried. I've heard that social distancing and lockdowns are being put in place to prevent the virus from spreading. That makes sense, but what does this mean to me, my HIV positive status, and my ARVs? Will I be able to keep healthy and also go to my clinic for my resupply of medicines? I thought others might have the same concerns, so let me tell you what I've learned from my nurse at the clinic. As COVID-19 is a new virus, we do not know yet how it will affect people living with HIV. But what we do know is that if you do not take your ARVs, HIV will be able to damage your immune system, meaning you are more likely to get infections. It is just as important to take ARVs regularly now as it was before COVID-19. This means you must not run out of medicine. My nurse told me that the health clinics are still open and we should all go for our normal review days. She also said I should try to come early in the morning as some pharmacies close before lunchtime. While sitting on the bus, I made sure to keep 1 to 2 meter distance from all the other passengers and to touch as little as possible. Everyone else was doing the same, which made it easier. We all understood it was important to protect each other. I was so aware of not touching my face in case I touched something with COVID-19, then went on to touch my face. When I got off the bus, I made sure to use one of the proper hand sanitizers. Once I got to the clinic, they told us to wait outside as they only wanted to see a few people at a time. We were told to queue 1 to 2 meter distance apart. I saw some friends there and practiced greeting them with a wave rather than a hug so that we did not touch each other. It felt a bit strange though, but hey, we all laughed.
Wow, wonderful. Such a practical example, and incredible just to know that that those videos are being produced by young people for young people. So thank you for that. Nicola, I'm going to thank you. I'm going to leave it there and come back to you if I can, and come back around if I can. Wonderful. So I'm going to move us to Kenya and to Florence then. And we're delighted to have you, Florence, such a strong connection between Kenya and Ireland and the partnership you're involved with. We would love to know just a little bit about what has the impact of COVID-19 been on your community health work in Kenya. You might have to unmute yourself.
Thank you, Nadine. Okay, so Brighter Communities is an NGO working in Kenya since 2002. Our program areas include education, health and economic empowerment. Our health program has a multifaceted approach, which includes skills, education, awareness, service strengthening, and also infrastructure. And it focuses actually on 3 levels: the individual and family level, the community level, and then we also have the formal biomedical system. So the individual and family level is all about including skills. It's also about enhancing awareness and capacity development. The community level is a bottoms-up approach which involves training members of the community to be community health volunteers and supporting them to improve on the health of their communities. On the formal biomedical system level, this is all about strengthening the health system. And we facilitate a partnership between Londiani Sub-County Hospital, the Mayo University Hospital, the National University of Ireland, Galway, and Kenyatta University in Nairobi. So as this webinar is about communities, I will primarily focus on communities. Our county of operation is Kericho. It's one of 47 counties in Kenya, and it is home to almost 1 million people. It is predominantly a rural area where about 90% of the population are subsistent farmers. Kenya had its first case of COVID-19 announced on March the 13th. The government acted swiftly and imposed a curfew. Schools were closed down and there was restricted travel, and people were asked to work from home where possible. So for us at Brighter Communities, the priority became the safety of our staff and their families in this. So we were trained on COVID-19 before the first case was announced, and an incident management system was put in place. We met as a team and we discussed on how we could respond to this emergency. Our programs, they still remain relevant, but we had to find a way of delivering them safely. So our 18 years of experience and our network across Kericho County is one of our greatest strengths. So this network includes community health volunteers, it includes facilitators, it includes teachers, amongst others. And so we've leveraged on this network to respond to the COVID-19 crisis. So to date, we have supported the training of 1,085 people as COVID-19 sensitizers, who have now been able to reach 45,000 households across the county, providing soap to the vulnerable, teaching about respiratory hygiene, hand washing, and social distancing. We have also been able to provide 22 town centers and 163 health facilities with soap, with hand washing containers, and with also communication materials for sensitization. The pandemic has highlighted the gender gap across the world. So we've been working to bridge this gap. For example, our menstrual health program has pivoted to allow girls and women access sanitary products locally in their communities. We are also currently working on the completion of the isolation wards in 2 health facilities. And yesterday we began supporting the training of 400 healthcare workers across our county. COVID-19 has had an impact on the delivery of routine health services in our county. So a few statistics that I can share. There's been a 39% reduction of the people attending outpatients in health facilities. We've also seen a 12% reduction of women attending antenatal care, and 45% reduction of women attending health facilities for postnatal care. And there's also been a 3% reduction in deliveries in health facilities. So that's what, in a nutshell, we've been able to see.
Wow, Florence, thank you so much for sharing that with us. It's really striking how the same for Kenya and Zimbabwe, how integral your NGO, the community response, is as part of the health system response. I mean, maybe to ask you, how do you think that the community response that you've been involved in and initiated has actually improved the overall response to COVID-19?
Okay, we have seen a mixed community response. At the very onset, there was a lot of fear in the community, but this was compounded by how the restrictions were enforced in some places, particularly the curfew. But with the ongoing sensitization, we have actually seen a 66% increase in hand washing, and across the households. And we've also noted that the sensitization has helped to alleviate the fear, because people are now informed, they know at least who to talk to, where they can go for help. But on the restrictions, the restrictions have been in place for three months now, and people are slowly reverting back to normal. So for example, markets which had been closed are gradually reopening, and this is encouraging crowding. Another challenge is the stigma around COVID-19. As a result, the probability of people discussing or disclosing COVID-19 related symptoms is very, very, very low. And then the other, something else that we have also noticed is that the livelihoods for the majority of people in the population have been greatly destabilized. As a result, there's a growing struggle to make up for lost income and to keep to the government restrictions. Additionally, due to other weather-related catastrophes, we've had flooding, we've had landslides that have displaced a number of our community members. And so keeping to the COVID-19 measures has become a secondary priority. With the reduced numbers attending health facilities, the impact on the communicable diseases such as diabetes and hypertension is not as yet known.
Wow, thank you, Florence. I'm just thinking, you mentioned earlier on that there's been a reduction in the amount of people coming to clinics, and I think we've seen that. We've seen it in Ireland, we're seeing it in all countries affected. How has that affected particularly your work on maternal child health, which I know you have been involved in for many years together with the Mayo General Hospital in Ireland? How has that been affected?
Okay, we're still in the communities. We're still working in the communities alongside the Ministry of Health team. So because we've been working closely with the community health volunteers, they are helping in keeping track with the antenatal care program in the households. And also we have our outreach programs in areas that are underserved. So mothers are able to visit these outreach clinics, which are ongoing. We've maintained, those have been maintained in the community. So they're monthly. And so we've actually seen a growing numbers more so in the outreach clinics. And I think we're relating that to people avoiding travel, you know, to other health facilities. Yeah, but because of that as well, that has contributed to the reduction in the numbers of health deliveries. And it will be some time for us really to get to see the full impact of this of the COVID-19 changes.
Florence, thank you so much. That was so practical and so thorough. Gave us a really good picture of what's happening and what's possible. So thank you for that. I'm going to leave it there for a moment and move over to Juan in Vietnam, if I can, and welcome Juan. If you're able to put on your video, it would be super. We could see you as you speak. There you are. Perfect. Beautiful. Lovely to see you, and welcome to Ireland again. And you are muted at the moment.
Yeah,
great.
okay.
There you go. And just before you came on, we were talking about Vietnam, and we were just just remarking on how COVID-19 seemed to come under control so quickly, and just wondered if you could describe the situation for us in Vietnam. You know, what kind of impact has it had, particularly on vulnerable communities?
Yeah, so just quickly about the situation in Vietnam. I saw that you shared the link on CNN about the control, the success of Vietnam in controlling the COVID-19. So we have by now 7 weeks without any community case. So we have no new case in the community. There are a couple of new cases that diagnosed between, among the people who returned from abroad, and they came from the evacuation of our people, the Vietnamese from other country, by the charter plane, and then they would be tested at the border, and everybody was in quarantine. I mean, if you enter Vietnam nowadays, you'll be put in quarantine for 14 days until you tested negative for 3 times. Then you would be you can go home. So we don't have any new case. We have a lockdown for 3 weeks. So the first 3 weeks of April, the lockdown was removed from the 22nd of April. So life is back to normal now. The street is very busy. The market are busy. Everything's back. Massage parlor and football match and everything. So we are back to the traffic jam for a couple of weeks now. So that is the epidemic in the country. So it's almost over. What has not been over is the fact that the border are still closed. So it affects a lot. A lot of people, although we don't see it very obviously, because everyday life seems to be back to normal, but because the border closed, the export are slowed down, also the importation, but the export slowed down, and our economy is based on exportation. We have a contract with a lot of companies, so seafood and clothes and shoes and rubber and coffee is supposed to go out. That everything slowed down now. Many industrial zone, factory and company only work at the half of capacity, or some company or factory even closed down. So the life of people are seriously affected. The worker earn much less. There are much less job, much less income. So people's life, in particularly the poor, the people who live hand to mouth, are severely affected. Yeah, so the lockdown, during the lockdown, the people who because we have the poorest people really live hand to mouth. They find money to eat every day for every meal. So the moment they stop working, they stop eating. And most of them also stay in a rental place, so they can rent by day, by weeks, or by month. So when you don't pay the rent, you are on the street. So yeah, so that is it affects severely. The most severely are the vulnerable people and the poor people. So as the sex worker, during the lockdown, you can imagine the sex worker don't have work. The drug user are also severely affected, because during the lockdown it's much more difficult to buy drug, and drug is much more expensive. So they are it's really difficult for them. And then the methadone patient, because they have to co-pay. Then when they don't have money to co-pay, they are it's very challenging for them as well. So so we see a lot of suffering during and after the COVID. People continue to suffer. We continue to see people who don't have a food to eat, and who don't have a place, who cannot afford to pay the rent. Yeah.
And Juan, can you share with us just some of the ways that SCDI and other organizations that you've been working with have been able to respond and continue to respond? What has been your community response, particularly for these vulnerable groups that you've just mentioned?
So we start first by making sure that the community worker, we have about 700 community workers who work with us. So they are not our staff, but they are our outreach worker. We make sure that they receive their monthly incentive, because so Vietnam has been affected since long time, because we have a long border with China. And you know that when the China the first cases that found in Vietnam was in January. So about the same time as the epidemic erupted in China. So the country has been on alert since January. People start to lose jobs, restaurant close since January. So since January, we see that among our outreach workers, people start losing job. Most of our outreach workers have another job to earn their living. So outreach worker is only, is they do it on their, like, as a part-time job. So the incentive that we pay them is only one part of their income. But when we see that they are losing other job, the income that they have with us become the only source of income. And because of the slowdown and then the lockdown, we have a not official lockdown, but the isolation, and the government start to restrict the movement since January. So because of that many of our project activity cannot be implemented. But then we make and donor was not really reacted by then. So we made the decision that we pay our outreach worker anyway, even if they cannot do the work because of the travel restriction. We make sure that people get to eat. And then we order protective equipment. We order hand sanitizer and mask from very early before the lockdown happened. Because we know that once the lockdown happened, if you don't have a mask, we cannot even go out. So so we order masks and we send it to provinces to distribute to our outreach worker and also our client from very early on. So it's actually mask and hand sanitizer arrive before the lockdown, so that help people, at least they can move a little bit, because with our mask you would be you cannot move. So pay people, providing protective equipment. But then because we work very closely with the community, we start to get the report that our client start to experience food shortage, or there's a risk of starvation or being hunger. So we did some kind of very rapid assessment, and we found the people who fainted on the street because of being hunger. So so we start to provide we do a food distribution program for the homeless people, and for the slum people living in slum, in the poor area. And we increase our activity during the lockdown, because the lockdown means no restaurant, no cafe, nothing. And so the homeless people will surely be hungry, because they not only that they don't have money, but they don't have food. They cannot find the food. So so we increase the distribution of food. We find a lot more people on the street, and then we also increase the distribution of a food package, rice and oil and egg and things, peanut, to the slum. Yeah, and we do it through our volunteer, but also through our community network. So provide to the methadone patient, to the people living with HIV, to the sex worker. So that and as we do that, and we raise funds from individuals, so people contribute money, people contribute food. We distribute thousands and thousands of ready the hot meal, and about we distribute 36 tons of rice and other things, and salt and mask. Yeah.
You had a campaign that was called one egg per day. I saw that campaign, which was delivering food parcels that had an egg and had masks in it. Can you just describe that to us? We've lost your video.
Yeah, so we have a kind of informal charity fund called One Egg a Day. It's really to provide food, nutrition to the poor people. So we run that campaign during the COVID, during the lockdown, and ask people to donate. So people donate food, people donate meals. So like in Hanoi, we got like the donation of 6,000 meals. Some people just like donate 100 meals a day. People donate eggs. It seems like 1 egg a day is very simple and easy. And so some people donate 1,000 eggs, some people donate 600 eggs. So, and masks and hand sanitizer and soap and cooking oils and rice and peanut and dry meat, etc. So we we run this campaign in 12 provinces, and people donate everywhere. So people send money as well. So we managed to keep people fed during the lockdown, and after that even. And but what we find interesting is that through this activity, we do not only serve the community that we usually work with, drug user and sex worker and people living with HIV, but we come closer. We interact with the other vulnerable population, the homeless, the urban poor. And we now we expand our our target population. And we go deeper in there to understand their vulnerability, and based on that, now we go into the second phase that we call recovery and development, beyond the food and the mass distribution.
Thank you so much, Juan. There is so much. I see somebody in the attendees box has also said there is so much to learn from Vietnam, and I can't echo that enough. So I think I'm going to move along to Blessy, and hopefully I can come back just for a final word from you. So thank you, Juan. And I'm going to move to you, Blessy, if I can, and just ask you, last week we were very lucky to have Dr. Luchika from the Stop TB Partnership with us, who outlined the situation in relation to TB, but could you tell us a little bit about the situation for communities of people who are affected by TB? How has COVID affected them?
Thank you very much, Nadine. I'm really, really glad that TB is part of the conversation around COVID. And I'm really delighted to be speaking about TB that I'm extremely passionate about. I'm with the Global Coalition of TB Activists, as Nadine already mentioned, and towards the end of March, towards the last week of March, when COVID started coming into different countries, into the news, countries contemplating lockdown, we did a very quick survey, a global survey, and it was very interesting to see what the initial responses were. We had about 18 countries who responded, about 5 countries from Asia Pacific, Southeast Asia, about 9 countries in Africa, and we had a couple of countries in Eastern Europe and Latin America. And because countries were all going into lockdown, and some had already gone into lockdown, like India, one of the major issues that was raised by the respondents was the public transport had come to a standstill. So then how do you access health facilities for diagnostics, for treatment, and other services? There was serious drug shortages and stockouts because flights were being cancelled. So if you hadn't already, put in your requests, and if it had been done recently, then drugs coming into the countries was a huge issue. OPDs were closed down, DOT centers were closed. So there were serious treatment disruptions. And then things like rerouting of health staff that were managing TB health posts to COVID response. Patients would go to the DOT centers and find that there was nobody in the health center to take care of them because everybody was so busy with COVID. And then because it was so early on, the issues of nutrition didn't come up so much, very few, only about 7% of the respondents highlighted this as a challenge. But as we saw later on, a month into this, migration, hunger, loss of earnings was a huge, huge issue. So this was how TB was really falling off the radar completely because of COVID.
Thanks, Blessy. I'm just wondering if you could you say something about, your GCTA has a reach that is global, and I just wonder, have you already started, particularly in the light of those challenges that you've outlined there, have you seen examples where communities have responded from different regions, different countries, even a few that you could share with us? I think we're learning so much today.
Yes, thanks, Nadine. So to answer that question, I'm going to do it at different levels. So the country, regional, and the global level. So to give you an example, I'll take India. Justifiably, I'm based here. So India went into a complete lockdown without any warning. People were left with, like the daily wage earners really suffered. They couldn't pay their rent. There was no earnings. They were being kicked out of their homes. Then people started wanting to go back to their homes, because these are all migrants coming from different states, coming to the metropolis like Mumbai, Delhi, and Calcutta, Punjab to work. And then they all wanted to back, but there was no transport. So we heard horror stories of people attempting to walk hundreds of kilometers, 800, 1,000 kilometers, and we saw pictures. I mean, it was covered by international news, so all of you would have seen. And the number of people who died on the way, many of them were also TB patients. We heard horror stories from hospitals where there was no TB drugs that were reaching, and about 100 patients died, 120 patients died. Prisons, so treatment interruption really was a huge issue. So as a community in India, we got together. We first wrote to the health minister. We wrote to the Prime Minister after that, and we highlighted the challenges. And we gathered information from our volunteers on the ground, to ask them suggestions of how this can be addressed. So we were not just highlighting the problems, but we were also giving suggestions from the ground. Then we also wrote to our Central TB Division, and we said, directly observed treatment doesn't work. You cannot have them in this situation coming once a week or twice a week is impossible. You need to issue them at least 2 months supply of drugs at a time. And from our side, our community volunteers will take on the responsibility of supporting them for adherence and other things. So that was a good thing. The Central TB Division actually sent out a letter to the states and the districts to ensure that this happens. But we all know that a letter doesn't mean implementation on the ground. So again, the soldiers on the ground, the community volunteers, again, find out if this is really happening and highlighted the challenges for us to take back. Then we know that from many countries like Kenya, we've heard from Mozambique, we've heard from Cote d'Ivoire, where the community volunteers are actually supporting with follow-up at the district health center level, primary healthcare center level, and also supporting and linking patients needing care and support, to volunteers, to peer support groups, just whatever we can. And initially it is a very sort of an unorganized response to the desperate need. But we hope that this can become, formalized, and this can become the rule by which we all work. Then at the region,
Can I just come in there? I just would love to, I would love to hear from just the panelists, just as we come towards the end of the webinar. If I just asked you for a final, just give us a piece of advice from what you've learned from the community response of TB. What would it be for everybody, just as quick as you can? See, for me, in everything we do, strengthening the core is most important. Yeah. So I think the community is the core of any disease response. They're the backbone, but seldom recognized. I mean, even from our panelists, we heard that. For policies to be translated onto the ground and implemented, it is the community that can actually ensure that this happens. And communities are also our early warning system, of any challenges and interruptions, and they give us a real-time feedback. So I really would like to stress the importance of investing and building capacity of communities for a sustained response to any problem. Thank you, Blessy. That is really clear and super wisdom. And we've also just put in the chat some resources that people can go to if they'd like to learn more about the community responses relating to TB. So I'd love to come back, if I can, to you, Nicola, and just ask you just to give us a final, leave us with something in terms of community responses from your perspective, as quick as you can. Thanks.
Sure, I think we were just hearing about it, but I think from the community's perspective, there is obviously so much we can do. But it can't work in isolation, and we from our experience, we just have to partner with the health facilities, with social welfare, to make sure that what we're planning and delivering is done in partnership, so that we can be picking up on the issues from the clinic and vice versa, that young people in need of additional support from the community can be referred back to the clinics and seen there. So it's a partnership.
Well, thank you for showing what an example of partnership between the community and the health and the formal health system is like in Zimbabwe. And I hope people go and have a look at Jandiri and Africaid's work to see more about that. Thank you, Nicola. Florence, just coming to you back in Kenya, what would you leave us with from your experience? And you need to unmute yourself. Thank you, Florence.
Sorry.
There you go. Yeah. Oh, you're muted again. Sorry, Florence. Ellen, can you unmute Florence?
Sorry.
There you go.
Sorry.
Good.
Yeah.
Thank you.
Thank you. Yeah. Sorry about that. As an organization, we believe in the power of communities working together. And in the words of Kenya's Cabinet Assistant Secretary, Dr. Mercy, she said, community is at the center of gravity response. So as such, as an organization, we'll continue in our efforts to strengthen our communities towards this end.
Oh, thank you, Florence. Thank you so much for that. And to you, Juan, for a last word before we close.
Sorry.
I'm just coming over to Juan back in Vietnam. Yeah, thank you.
Yeah. Yeah, no, I think it's in terms of response to like public health response to COVID, I think we after this, so the world will have a lot to learn and to share. But I think the COVID exposed the people who are most vulnerable in the society. So the vulnerable people would be vulnerable to anything, and they would be the first who suffers not only from the health perspective, but from everything else, from all other economic, financial, etc., safety, security. So I think we need to keep a very close eye and working closely with the most vulnerable population and community in any circumstance, particularly when the disaster like this happen, when you have a crisis. Think of the most vulnerable people.
Thank you so much. Thank you, each and every one of you, for making sure that we see how important the communities are in the response, and how no matter what the issue that we're dealing with, communities manage to find creative solutions and ways to inspire us all. So thank you so much. Hala.
Okay, thank you, Nadine. And also thank you to our speakers for sharing with us all those lessons about community responses. I like to learn from that. So, and we hope also to host you in one of our coming webinars. So next week webinar will be about exploring a planetary health response to the pandemic. And the recording of this webinar will be available later. And as we are running over the time, I'm saying goodbye and thank you, everyone. And see you next week.
Thank you. Thank you very much.
Thank you.
Bye. Bye. Bye.
Thank you.
Thanks.
Thank you, everybody.